Thank you for coming this morning. Do we have any apologies?
About attendance, but I haven't heard anything
No,
about not attending.
She wasn't very well yesterday.
Why?
So I
Want me
think
to
we-
put her as
Thank you. Anyone got any declarations of interest beyond their officially declared?
None at this point, Chair.
Thank you. And minutes of the last meeting. Any comments on them?
Happy to move, Chair.
I'll second.
Have to move in second, yeah? Okay, we'll accept those as being correct, thank you, Fiona. Then we're on to update from Yorkshire Ambulance Service. So if you could introduce yourselves and
Good morning. Morning. I'm Nick Smith, I'm the Chief Operating Officer of the Yorkshire Ambulance Service. I'm the Head of Operations for Hull East Yorkshire and North Yorkshire. Good morning, David Benshaw, I'm the Head of Operations.
Okay, thank you. Is there anything that's not in the report or anything you'd like to highlight from the report before we start interrogating you on this?
Don't do interrogations here, Chair.
Would it be okay if I
Well,
just spend
please.
a minute explaining how the answers of the model operates?
Yes, please.
Maybe that may help answer some of the questions. So we have really three areas of ambulance service. We've got the call accident emergency, A&E, which is very much around responding to 999 calls. So we take the calls and then we process that and send an ambulance. And we also have the what we call 111 service called integrated urgent care, which is basically 111. And finally, we have our patient transport service called known as NETS. So they're the three services that we provide to the patients of Yorkshire, down to South Sheffield, to Ingleton, Whitby, obviously Hull as well. So really big geographical area that we cover. So let's start off with the 999 call. So remember the public as an emergency, means 999. That call is taken by our what we call emergency call health advisors, and they're based either in York or based in Wakefield. Now they're non-clinicians. They're trained to use a software program that has a number of questions that they take the caller through, and that can give some advice. If it's cardiac arrest, for instance, we're able to give life-saving instructions to provide support until the ambulance gets there. Same for childbirth and same for most bleeding. So though not clinicians, they provide a really good service for patients who are on a telephone. They then ask these questions and they fall into different categories. So we have category 1 down to category 5. Category 1 is immediately life-threatening. So that's somebody who's had a cardiac arrest effectively, or in the context of probably been on cardiac arrest in the next few minutes. Go on category 2, which again is poly patients. It's patients who are having strokes, chest pain, severe bleeding. And then we have 3s, 4s, and 5s are quite interesting. They're the calls that we receive that straight away we know high probability that we don't need an ambulance, but we need something for advice. And I'll come on to how that works later. So once we've got the category of the patient, then it's around dispatching an ambulance to those patients, or, which is probably changed in the last 5-10 years, a lot of the calls we get now, we have paramedics working either in our contact centres or actually working within the area as well. We have a number of paramedics who don't respond to calls, but with telephone calls. And they give advice to patients and they utilise any alternative pathways in the area. So a patient may have fallen, they're able to contact the falls team and allocate that job out that way without sending an ambulance. If we do need to send an ambulance, which is probably about 80% of the time we need to send an ambulance, then that ambulance is usually, well, in the past it used to be dispatched from an ambulance station. We don't dispatch ambulances from ambulance stations anymore, probably at the beginning of the shift. We're too busy. Our demand's gone up 50% in the last 10 years. So when we have an ambulance, it's usually becoming available at the hospital, or it's end of it's beginning of a shift somewhere. And probably that's what David will explain later around how our state's going to change, our ambulance stations change, condensing that together. If we don't have a spare ambulance, then what we try and do is locate that in the most appropriate place. on probability of where the next call is going to come from. And that's how that works. But really, reality is when we're busy, it's from the hospital. So that's responsive from the hospital to whoever the call may be. When the crew get on scene, they've got some options. They can either make a referral from scene to, again, one of the services, calls, or they can treat the patient on scene and discharge on scene, or we convey the patient to hospital. In the past, we conveyed the vast majority of our patients to hospital. That's changed over recent years, where about 55% of patients who call 999 actually get delivered to an AD department. That's our contribution to the health system and make sure patients get what they require. So that's an explanation of health around the context around the 999 service. 111. We have a system that's called Pathways. So when somebody rings 111, it's a lot more detailed questions and allows us to really understand what that patient needs and again identify what the most appropriate pathway for that patient will be. And that could be back to a GP, A&E department, or there's various other options, something called directory services that we're able to access. What we're in the process of doing at the moment is we're moving our 999 calls to be answered through the NHS Pathways system, so we can really bring together 111 and 999, so it makes it easier. So that's not passing the patient from one service to another. So that's where we're in the middle of that now. That comes by October. Then our patient transport service, that's for pre-arranged transport for appointments at hospital, renal dialysis, oncology services, eye clinics, and also discharges from hospitals as well to keep the system going. So I don't know, hopefully that's helped set some of the context and questions that they ask.
Okay, thank you. You mentioned, so did you say your demand's gone up by 50% in 2 years or 10 years?
10 years.
In 10 years.
So
Has capacity gone up by that amount as well?
yeah, well, it depends on how much funding we get each year. But last year, I think our capacity went up by 4% in this particular area, but it just depends. And this year we've had no additional growth apart from things within our contact centre. Operationally, we've got no growth funding this year. So the number of staff that we had last year, we've got the same number of staff for this year. Yeah.
And the 111 pathways, how well established is that now?
It's 10 years. The art's about to celebrate 10 years.
Right.
Which has been run very separately, even though it's within the art, it's been run very separately. And the last 2 years, we really started to bring that together.
Okay. Any questions? Sorry. Go. Councillor Randall, thank you.
Yeah, thank you, Chair. Okay, Tim, I'll let you off. Just a couple of questions. Thank you very much for coming to see us this morning. I know Friday morning, everybody wants to get things cleared off the plate for the weekend as much as you can, and we understand that totally. I've just got a couple of questions relating to, if I might, each of the 3 sections of the service that you've just spoken to us about. So my first is about the 999 service. Now, within other emergency services, if we've had what we call flood condition calls, there is a way of them being dropped down to neighbouring authorities. So, for example, if Homicide Fire and Rescue was overwhelmed with calls about a particular incident and all of the lines are busy, then it would go down to Lincolnshire, Norfolk, Herefordshire in that particular order. For help and support for residents calling. Do you have a similar arrangement within your service?
Yeah, we do. Yeah, so for a major incident, for instance, where the incident exceeded our resource capacity, we would look to use neighbouring trusts. Obviously, we covered the whole of Yorkshire, so Homicide and Rescue just covered the Homicide area, obviously. So depending on whereabouts the incident was within Yorkshire, we would look to again use neighbouring trusts. So sort of this. If it happened in this sort of area and exceeded our capacity, we'd be looking to get mutual aid from EMAS. And that's
East Midlands.
mutual aid
Yeah.
in that sort of area.
Yeah.
It was in West Yorkshire, potentially North West Ambulance Service, and to the north of the area, so North Yorkshire and my areas, North East Ambulance Service. say come down as far as sort of Cleveland, so
Yeah.
why not the option. We very, very rarely use mutual aid because everybody's under the same sort of pressures. It would only be for an extreme example. For instance, the atrocity at Manchester Arena
Yeah.
happened in the northwest area. We sent resources across from West Yorkshire to support our colleagues in Manchester.
Okay.
So only in extreme examples.
Brilliant, thank you. Can I continue?
Yeah.
Thank you. So the next one is about, in paragraph 5.4, you made reference within the 111 service about the mental health option and being put through to local mental health crisis lines, and it's managed by partners. Are there any issues with that? And if so, what are the ongoing implications for the service that you are providing? So, for example, you know, if it goes through to the mental health crisis line, but all you get is an answer phone and somebody will ring you back, sort of comment, that person is, their issue has not been dealt with, has it? And so they're going to call you again. So how often is that causing issues for you and the service that you're able to provide for other users?
So there's a fallback on that. So if a patient presses the button, goes through to the health service and not able to be a call accepted, it will come back into 111. And
Okay.
it will be the same level of service that would be provided if the option didn't exist. We have concerns that maybe if capacity wasn't there, then it would increase our demand back into 999 as well. Not really seeing that. It seems to be, there's obviously pressures everywhere,
Yeah.
but we've not anticipated, like, no, we've not seen any pressures on our service as a result of that. It's been relatively successful.
Okay. Good. And the final one I have is about the non-patient. I mean, it's over 20 years since I was involved with a review of passenger transport services when I was working in primary care. So I know things have moved on an awful long way since then. But recently there has been some media coverage about patients that have had appointments in hospital, they've had their transport booked and the transport hasn't turned up. How often is that an issue for residents and service users within your area? And if so, what is being done to resolve that issue so that people do not miss hospital appointments and then get put back on waiting lists through no fault of their own?
I think the incident as well.
It was. So I'm seeking reassurance it's not an issue here in Yass.
There's an organisation move 2,000 patients a day, so I'm not going to pretend that there's not issues where people are late. What we do is if we are unable to convey somebody, we try and let that know the day before. I think generally it doesn't happen very often. I can't give the figures on there. But maybe it may happen, but we do everything we possibly can for an time. We also have access to, we have a model where we've got our employed staff and our ambulances. We also have access to using taxi companies, private ambulances as well. Ideally, we want to utilise our resources, but it gives us some flexibility to, if there's something short notice, we can usually find an alternative route to do that.
Okay.
Thank you. Councillor Waring?
Thank you. When I read through the paperwork, there's quite a few references in here to how the service is being stretched. There's comments about high levels of operational demand across the areas. The increase, I think, says 8.1% from last June to this June. There's comments about delays in handover at hospitals. But then when you look at the calls coming in, when I looked at some of the figures, 16% of people who ring 999. That's what I looked at. Should actually be ringing 999. And there's 40% of people that actually tended by the emergency, said the accident emergency. It shouldn't actually be conveyed. So I'm just interested in that in the triage process, because is it a problem that we're not resourcing the service enough, or is it a problem in the triage in that there is alternatives? And I think as a second question, are people ringing 999 out of habit? And if they've got anything problem, they just ring, and there are alternatives that they don't, you know, there's actually attending at the doctor's, making appointments, you know, ringing 111. There are a whole, or not actually ringing, but there are a whole range of things that we could do. And they just ring you out of habit because that's the easiest way. And what are we doing to dissuade people from using the service inappropriately?
Yeah, and there's lots of questions there, so I may need to be recap. So obviously, as Nick's explained, when somebody rings 999, they go through a series of questions and a triage comes out with an outcome. Historically, we've used AMPDS, Advanced Medical Parameter Dispatch System, for that. What that system is aimed to do is really cautious and it often over triages. And then that's when we end up with an ambulance going. And then, as Nick said, only 50% of attendances we actually take to A&E, we find alternative pathways. And I think the question you're saying is why aren't those patients finding those alternative pathways sooner? One of the things, again, as Nick said, is we're moving to NHS pathways. So we're moving away from APDS to NHS pathways, which there's a lot more questions and it's a lot more in depth too. And with the aim being that we can, at point of call, direct patients to the right place. And we've had an increase in our clinicians in EOC to talk to somebody over the phone to avoid an ambulance being dispatched. With regards to numbers of pathways and things, we do certainly in the area there are a huge number of pathways. Unfortunately, they're not, a lot of them aren't 24 hours. The fact we attend many patients where it would be suitable for a pathway, but it isn't available to us. It's out of hours or whatever it may be. What we are in the process of doing, we need to increase those pathways. We need to increase awareness of those pathways. And I think it's all very clear, certainly in the NHS 10-year plan, which recently been launched around the neighbourhoods and about patients being able to access healthcare locally to hopefully decrease that demand on the 999 service. I think ultimately what people come relying on is when you ring 999, you get an answer and you get an output from that. And I think a lot of patients struggle when trying to run GPs, whoever it may be, in getting a resolution to their issue. So the fallback is 999 or 1.
Who is responsible for trying to reduce those number of inappropriate calls to 999?
So it's something that we look at regularly. We have outreach teams that work for us. We work closely with local NHS providers as well. Same with accident and emergency, when we take patients that aren't appropriate for A&E, but it was our only option. So there's lots of work. It's very much collaborative working around looking at where we can, how we can solve that problem.
Thank you. Thank you, John.
Thank you. Councillor Henry?
Two very quick ones really, I'm hoping. I'm looking at 2.3, 2.4 and 2.5. So people can either put me right or put me wrong. Now, it shows that actually you get into places a lot faster. Your triaging off is working, but which I've just ticked good. So I'm assuming that's how your numbers are coming down for us. Yeah. So your triage is sort of working. Because it's early stages in some ways, isn't it? But when I'm looking at 2.5, the back end of 2.4, I'm looking at emergency departments and handover delays. And then when I really look at 2.5, I'm like, that's quite a lot of ambulances that are off the road, 33. So that is a lot of people in 24 hours that we're not helping and supporting at handover. So I know there's been a lot of work at handover and you can't. How does that work from your end now?
That number there is for the old people.
Yeah, no.
Yeah, so the local movements do.
I could put the performance bit, and then I'll hand over to David. David's been working tirelessly with the team in Hull to improve the handovers. Yeah. So as Nick said, category 1, category 2 calls are almost serious and life threatening. That's where a lot more focus is. The target for category 2 is 30 minutes, it goes 12 to 18 minutes, so that full sheet's been changed to 30 minutes. Gas are achieving that target as we speak. See it today at 25 minutes 49 seconds within the whole area, that's 24 minutes, 36 seconds. If you're wrong, you're not taking the opportunity to find out that that's a 12-minute improvement.
It is, yeah, absolutely.
Last year. That was when we did extensive recruitment last year. I think I spoke to you last time I came around. We did some international recruitment. We did a lot of regional recruitment as well, paramedics and non-clinicians who work with paramedics. So yeah, we did a lot of work on recruitment, getting staffing levels right. The issue was that a lot of them were sat at hospital for too long. Dave and I went down to London Ambulance Service to see what improvements. They've made some significant improvements around the handover at hospital. We came back with a bit of a proposal and David worked that up, which did us, majority of that is the improvement in 12 minutes. David, you just want to talk about the transfer of care initiative that we undertook at Hull? It'd be wrong to point out that Hull was the first area to go live with that. We've subsequently rolled that out to within our area, York, Scarborough and Harrogate, within the North Yorkshire area. And then that's been rolled out across all the other areas of the Yass. So South Yorkshire, Sheffield, Doncaster has now gone live. And I think 2 sites in West Yorkshire have now got money as well. So the initiative that we started in Hull has now been rolled out right across Yorkshire. So I'd love to see this transfer of care.
So transfer of care has been mentioned a lot throughout this document. It's essentially what that was is we've said when an ambulance arrives at ED, we have to safely hand the patient over into the care of the hospital department. Unfortunately, this time last year, certainly over the winter of October, November, some of our crews are waiting for 37, 8, 9, and even 12 hours to hand the patient over. And that was causing us significant issues. Obviously, most of our ambulances were tied up with ED. We weren't able to respond to patients. And as a result, obviously, our response times were alarming, certainly at the beginning of the end of last year. So we brought in transfer of care. It was a SOP that we wrote, and the idea being that it was the safe transfer of care of the patient over to ED with a maximum time of 45 minutes. So the ambulance will wait no longer than 45 minutes. If we get to the 45-minute point, the ambulance will leave. That does sound a bit scary that we're just going to leave a patient in ED, but be assured, every patient we were taking to ED and we were taking them there had been assessed and had been treated and were deemed suitable to wait. Really, really important patients don't wait to ED, take them straight to their own department. What our concerns were the number of patients in the community that were unassessed and had not been seen by somebody. And that was our biggest risk. There was risk everywhere, but it's about weighing up the biggest risk. So we worked incredibly hard with exceptional partnership working with Hull Royal to bring transfer of care in over what was one of our most challenging times, December. We had a number of incidents and we finally decided that actually we can't continue. This risk is so huge. So we brought transfer of care in, and almost instantly our improvements were seen overnight. We bringing that transfer of care in, and all the metrics instantly improved our response time. We did it in a systematic way. So we started at no longer than 80 minutes, then went to 65 minutes. So we did prepare for that, because what we didn't want to do was move all the risk to ED, and what that means is a bigger response from the hospital, which we got, which was really encouraging. So as I said, we worked tirelessly. We did that. There was lots of cultural changes with our crews as well to make that happen, and lots of learning along the way. As I've said, it was incredibly successful. We have now decreased that even further, so the crew waits longer than 30 minutes at Hull Royal. And as Paul said, we now roll that out across the whole of Yorkshire. And not only that, the number of meetings and phone calls I've had from trusts up and down the country that are looking at this, because Hull, the handover time was one of the worst in the country, and has now become one of the best. It was a hard work for the sites.
Well done.
Yeah, thank you.
They did a brilliant job, yeah. Like one,
Very long.
it was this team as well, but there was a lot of groundwork put in place. It wasn't another thing. We worked with the hospital tirelessly to make sure that everything was in place so that patients were at risk to be able to.
So is it okay to just ask a secondary question? Is there anything else you think that you need to make it better and keep it sustainable?
Oh, here's a question.
Yeah.
And if it's working, we want it to keep working.
Absolutely is working, and obviously there's always more, the target's 50 million.
Yes.
And that's what we need to get to. I think, just to be really clear, I think solving that problem is incredibly difficult, because it's not just an ambulance problem, it's not just an ED problem. Where
bed
the
blocking.
symptoms of the problem, if that makes sense, it's a throughout the whole system,
Yeah.
the NHS system.
What would make a difference, going back to the previous question, is the amount of patients that we attend. Like David said earlier, about 50% of them will convey through ED. So less patients will go through mold and triage, and mold can refer to other pathways. Less opportunity then for us to convey patients, because obviously, like David says, we use the cause of some of this fighting out patients that we're taking into what is obviously there's only a finite space in the anyone who's been down to the whole rail will see it's busy pretty much all the time. So the more we can do to refer patients down alternative pathways, less patients we can refer through ED, the better.
No, that's good.
Okay, thank you. Anybody else? Councillor Ben?
Thank you. Just a quick one. I was looking at under 2.9 improvement initiatives, and it's the last one about the staff survey results. And creating a safe workplace and support, etc. for the staff. How are you looking at doing that? The support, Ollie?
Yeah, so obviously a number of initiatives. One thing, certainly from health and wellbeing of our staff. Obviously, when I mentioned about the long waits to ED, that was horrible for their health and wellbeing. That's not a job that they want to come into, where they're stuck in ED, not being able to respond to patients. We've seen a huge improvement, and that was reflected in our staff survey. Certainly the transfer of care, the fact that they were getting to more patients, and we brought in some more work-life balance friendly rotas for our staff, which improved our sickness, improved our staff's health and wellbeing. And then also we've launched a number of initiatives, certainly on the back of kind of national campaigns around sexual safety charter and all of those things, which we are dealing with through a process now, which historically we've
I was just going to say, so just on back of what David said, a lot of our staff, not a lot of our staff, we've seen staff leaving the organisation because it wasn't the job we joined to do. So we didn't join to stand at whole work for 12 hours. It was eating into their work-life balance. Staff were being laid off every day. There was missing meal breaks, etc. Because of the improvements in that hospital, that's turned around completely. Staff are getting regular breaks, and as a consequence, people are looking to leave. So our attrition rates have fallen massively. Staff finding it a better place to work. You know, they were saying we weren't listening to them. They were saying we're stuck at hospitals, we can't get something to eat, we're being let off constantly, it's eating into our daily life, etc. Pretty much overnight, it was a quick transfer of care that changed.
There's something around violence. Big
concerns.
Around safety of our staff. It's a trend, it's a national trend. We've seen it year after year, haven't we, where more and more staff are getting assaulted at work. And with initiatives in, there's body worn cameras, there's all what's ready for police. It's just something that seems to be perhaps a societal problem where I see more and more violence. We do a lot of training for people as well, don't we? But it's just a different environment. It was in Polestar.
Yeah, just on that, our staff survey is telling us that something like 50% of our staff had experienced sexual misconduct from patients and relatives. So this is inappropriate comments or even physical elements from the public. Like Nick said, we encourage our staff to wear the body worn cameras because we can use that as evidence. It's really difficult when especially with our own responders, work on cars and going to member of the public's house, taking their word against our staff. So we're encouraging our staff to wear body worn cameras. It gives us that evidence, but it does seem to be an ever increasing problem for us, especially when our response times were like where we were getting, our staff were getting a lot of abuse because people get frustrated, and then the time we would wait for a response. We deal with those appropriately, and we have seen convictions from homicide police because our staff have been assaulted both physically and verbally.
No, thank you very much. Thank you, Chair.
Anyone else? No, okay, well, thank you very much for that. It's very, very positive and thank you for the work that you do. I've certainly experienced your services enough times in the last 10 years to be very appreciative of them and keep up the good work. Thank you very much.
Thank you very much.
Thank you. Thank you.
Thank you.
Thank you.
Needing no introduction. Hi, Erica. Good. Anything you want us to, or want to update us on? It's not
Yes.
involved.
And apologies, I have circulated some information that things are changing quite rapidly in the integrated care board. So apologies, I didn't get slides earlier to distribute with the papers, but I thought it might still be helpful just to give a verbal update and to take any questions. I have acknowledged the action from the last scrutiny in regard to a more detailed update on primary care. And we're working on that and also intend to invite our clinical directors who are the GPs who take the leadership role involved to attend the September scrutiny with me as well. So let's pick some of that up. So just to give you a little bit of an update, I'm sure it hasn't escaped your notice that the long-awaited NHS plan was published. We're just working through that and cross-referencing that with the our current plans and strategies for Hull in particular. The plan highlighted the 3 shifts of care, which are the predominant areas within the plan, and then there's a lot more detail which sits beneath that. But essentially, it's a 10-year plan to achieve a much more substantial shift from hospital to community care. It's very well with the what the ambulance service has just described to us, so that we have much more accessible community services at that direct point of need in the community. So we start to reduce our reliance on the hospital services and make sure that they are free to deliver the work that they need to do in terms of urgent and emergency care. But wherever possible, the majority of that is delivered from community settings. The plan, if you've had a chance to look at it, and I have sent a summary round, does talk about integrated neighbourhood hubs and looking at estate and how services might be configured around a particular estate. The plan actually talks about a population size of around 250 for a hub. Well, that would be the city of just about for us. So I think it's about tailoring some of those objectives and ambitions within that plan to actually build on what we've already got in the city and look at how we can take the principles but make it work for us in Hull. And we do have some good estates. We've got some relatively new primary care estate, and we're currently looking at the options of how we can optimise use of those buildings and make sure that we're coordinating care in the best way possible. It will require, as we've heard earlier, that access and hours are extended, and I personally think that's really important. I think there's lots of mixed messages and variation at the moment, but it's very hard, even if you work in the system, so even harder for patients to navigate where to go, when, hence you get the reliance on services like the ambulance service where people get an instant response. The other key priority is moving from analogue systems, so paper-led systems, to digital. Again, there's a lot more detail underneath that, but it is about empowering people and supporting them to use some of the technology like the NHS app to have more control of their health plan and how they access care. Again, there has to be a balance with that, but it certainly does need to be a move over the next 10 years as younger generations who are very familiar with that type of technology would expect to be able to access their services in that way. As we know, we still have to make sure that we manage that transition for people where that's not as familiar and they wouldn't be comfortable with it. And ultimately, moving from treatment models where people present when they're already very ill to that prevention. And we've done some really good work in Hull that we can build on in regard to this, working closely with public health colleagues around the tobacco control, obesity strategies, and our frailty service is a fantastic example of where if you're proactive and identify people early and put coordinated care around them, you can reduce reliance on hospital care. And we do have data and evidence now over the 8 years of the GBishop that proves that does work. So personalised care, making sure the patient voice is strong. Key areas to improve, we're very familiar with GP access. I was very interested to listen to the colleagues from the Yorkshire Ambulance Service. I think we've got a culture now around we don't think we'll get an appointment, so we don't try, and actually access is improving. I think there's still some variation which needs to be ironed out, but access has improved. You can get planned appointments that you can book ahead on Saturday mornings and in the evenings in Hull. So I just don't think we've got that messaging right, and people are quite rightly reacting to what they know, which is to, if you want to be seen, go to A&E or ring 999. When actually there are a range of services now, but we haven't got the messaging right, and we haven't got those pathways easily accessible for people to use them effectively. Looking at the more access, future of urgent care, that being 24/7, and care close to home. A single patient record is prioritised within the plan. Again, we've got elements of that. The frailty service have a workaround system in order to achieve that for our frail elderly. But we're not quite there in terms of that being systematic. So that would be really welcome from my point of view, because it's the one thing that teams of care, health and care providers tell us is the thing that holds them back. How to share information safely in order to transfer care and stop the process of making onward referrals and handoffs around the system. Integrated teams, we've started some of that work already in Hull. Mention it again, but obviously we've got the GBishop model to learn from. We've been working with our PCNs to understand population health data, and then we've been working with our provider services like City Healthcare Partnership, Humber FT, and our voluntary sector colleagues to say, right, what does that data tell us, and how can we reorganise your provision around particularly high complex cohorts of people who need extra support and need that support to be integrated. My thought is that if we get that right, we actually help with the capacity issue that we're aware of around services, because you reduce duplication and you make sure somebody's getting coordinated care by the right person in the right place. So whilst it can feel a challenge because we are dealing with limited resources, I think integration is one of the answers to that, because I do think there is still waste in the system that we can transfer into coordinated care. For Hull, we have an opportunity with our Community Diagnostics Centre and the Wilberforce Health Centre on that same site to look at how we might start to develop this model of a neighbourhood response. That service will open in the coming weeks. The staff are currently in there being trained, and that will be looking to be a 7-day service, working into at the minute we're looking at 8 o'clock into the evening. So you can start to see how we've got some building blocks for what in 5 to 10 years can become our neighbourhood health offer. So alongside the plan and what we have to achieve and how we have to work together to do that, there are also some reform and changes happening organisationally to the NHS, and I've touched on this briefly to the Commission before. But essentially, the Integrated Care Board will reduce in its size as an organisation to become one smaller organisation who will concentrate on strategic commissioning across that larger footprint of Humber and North Yorkshire. The strategy of Start Well, Live Well, Age Well and Die Well currently remains, but we will have a new operating model by January 2026. Which will be within the new cost envelope, which has essentially halved our running costs. I think nationally the thinking is that that cuts in of the management and bureaucratic costs associated with the NHS, and I personally would be positive if we do see that translating to frontline services. As a place, as a whole, as the Integrated Care Board represented in the city, we're looking at how we can make sure our existing partnership, so essentially our Health and Wellbeing Board and our Health and Care Partnership, can continue to take the work forward that we've probably been more directly involved in, but will be less directly involved in. So it's very important that our partners in the city, across adult social care, children's, community providers like health providers, our ambulance service, come together as a partnership and hold that strategy for the city and make sure that the directives that we've just heard around the NHS plan are taken forward and are translated into what our population needs are for Hull. So I think part of our objective as a ICB team in Hull for the next 6 months is to strengthen that strategy with the partners, to leave that in a positive place with the Health and Care Partnership. The Health and Care Partnership will remain as a joint committee of the ICB, so it will have some delegated authority and authorising powers for Hull. So I think that's where the discussions sit, that's where the decisions around how we're spending our money, what money are we spending, and should we spend it differently. I think that's where those conversations are had. And then our Health and Wellbeing Board, which is already well set up to provide strategic oversight to integration, tackling health inequality, really holds that partnership to account. I think that's all I had to say, Chair, and it's a bit of a moving feast at the moment. We have weeks of not having any information, then we get lots of information at once. But I'm very happy to take any questions.
Councillor Waring?
Thank you, Chair. I think we have talked about this before, but I was quite interested in the 3 changes that have been made, the hospital to community. Because you mentioned about the hub being Hull.
Could potentially be, yeah.
But what about the neighbourhoods?
Yeah.
What is the
Yeah.
what is the relationship there between the hubs and the neighbourhoods?
Yeah. I think it's for us to translate what that national policy is saying and how that would fit for Hull. So if you take it literally, a hub in the NHS plan would serve 250,000 people, and it would be a building, and you can see in the big city how that might then sit in a neighbourhood footprint. I think for Hull we need to look at how that works for us, and it may well be right to have, this hasn't been thought through at all, but say we said you've got a community diagnostic service and you've got a health centre on Albion Street, would that be, a central type hub where you could coordinate services? I still think for Hull, you need to get right into the neighbourhoods as well and use your population health data and say, but what do we need in this neighbourhood? So the work we've been doing, you could align to the 3 area committees, and you could say an area committee is a neighbourhood footprint, and we want to coordinate our services to deliver in that neighbourhood, and we look at the population health data. And I think some of my colleagues sit on the neighbourhood committees, and that has started to be discussed. You could look at it right down at PCN level, and you could say, Several practices form a neighbourhood. So I think that's for us to determine based on what works best for Hull.
Because when we talked last time,
Yeah.
printed off the map of where all the
Yes, the PCN.
the PCNs are.
Yeah.
And obviously they're all in, is it 5 or 6
They're-
different groupings? But those groupings are not geographic, they're not in individual areas, they're spread across the city. So one practice is got, I couldn't see how you could geographically do the PCNs. How geographically you could do them because they've spread themselves across the city. Now, there is a comment in here, and I think I saw it in paperwork somewhere about reorganising
Yeah,
that. I mean, is that,
it's a possibility. So I absolutely agree. And I think when primary care networks were first established, there was a little bit too much flexibility in terms of how they were formed.
Yeah.
And in Hull, we did have groups of practices form a PCN, but weren't necessarily aligned. So so modality, for example, or a primary care network in the city, one of the biggest, but they have a practice in a GP practice in Westall. They also have one in East Hull. I think what you need to, why I don't think that's necessarily a barrier is because think of the PCN as an infrastructure umbrella group who deal with some of the sharing the functions that make practices run. Actually, the neighbourhood work is in that practice. And so you might have an overarching PCN, but you would say in East Hull, we've got Bilton Grange, and we would expect them to work at practice level in their neighbourhoods. They may well have an umbrella organisation which helps them manage their administration and other functions, but actually I don't think it takes away from what the GP practice is doing in the neighbourhoods. But so that's one thing, and that's why we haven't let that stop us testing out that neighbourhood model. I do think it might change. I think the NHS plan talks about new contracts and issuing contracts to deliver neighbourhood health, where you could then determine and say, actually, we're not interested in your PCN footprint, we're interested in your practices and what they do in neighbourhood. Our practices are always, our PCNs are already sort of thinking ahead on that, and they have started to come together as what they're describing as a federation. And that's simply I know it's very confusing, 2 or 3 of the...
Again is what I'm thinking.
Yes, coming together as a collective to say, so you might, this is an example, you might get 3 of the big PCNs saying, we want to bid for delivering of neighbourhood health and whatever the specification is. So we will come together as a federation, say we could deliver this as a group. That's all the federation is. It's just a collective. So I think as that starts to take shape and as the expectation is more around neighbourhood, I think you'll see the PCN model change.
is the vision then, I'll use Orchard Park because we've got the Orchard Centre with a number of doctors' surgeries in there, dentistry, different things. That sits in perhaps 3 wards, University and Begley, Orchard Park, could provide a neighbourhood hub for about, I don't know what you've got, 45,000 people perhaps within those 3 wards, including children. And it would be it's more a central location that you can provide services. But the doctor surgeries that are there have patients in Cottingham and or across Hull.
But if they were commissioned to provide neighbourhood health, that would have to
Embed in the neighbourhood.
manage their lists, however the way they manage their lists, possibly, and deliver the neighbourhood health offer, if that's what they were.
And about 3 wards is that the sort of, because we've got a number of health centres like the Orchard
That's
Centre
right.
across the city that are
Well placed.
to do that sort of
So you would, so then you don't need to worry about the organisations. You're saying you want neighbourhood health in this area for this population, organise yourselves, demonstrate that you can organise yourself in a way that will deliver all these things. How are you going to do it?
Well, on that note, I'm going to be an awkward one for Brian
It's all
in
right.
Orchard Park. My doctor's over in Bransham, I'm not changing.
Well, absolutely, and this is about, this is about the patients, so absolutely. So all that access, that choice has to be built into that model. Yeah.
Good.
And we
Because I
do,
was scarred by modality.
we do have some
Good, terrible.
opportunities in
Yeah,
the city. We've
absolutely.
got some estate, we've got good services,
Yeah.
but they aren't joined up.
Mm.
There's an opportunity to join them up, and there's an opportunity to specify how that will work.
I had more comments, sorry.
So it's councillor Wood before you, sorry.
Yeah, I was going to make two comments about what you're talking about, because I know that I've recently had two people, with one particular practice group, do you know what I mean, that keep getting offered it's modality, that, sort of live Coronation Road North, and they're sort of offered things in at Diadem, and that links into what was said earlier by the ambulance service, because that sort of sends them to 999. Do you know what I mean? Because there's no way they can
Get this.
even contemplate. Just the thought of getting all those buses across there is just too much, and we need to sort of address that. But a totally separate point is because you were mentioning about patient records and things like that. I've also had people recently contacting me, partly because of the national media about this and things like that, with real concerns about the risk to their records, particularly if it's outsourced with companies, and who are those companies going to be and things like that. So I think there's a big piece of work there about confidence with the public, but also security. Good points, Robin.
I have a few questions about.
Yeah, and it's a comment, not a question.
Sorry.
Doesn't it? Yeah, no, sorry, I was speaking out loud.
Mine's a comment. I mean, having worked in primary care for a number of years, I do know the type of characters that you're dealing with. So good luck. That's it.
Yeah,
It's just a
sorry.
comment.
Okay, sorry, councillor.
Yeah, sorry, I was just echoing what Councillor Wood had said, but there was also the issue about artificial intelligence as well. When I see that, I get very frightened. So how is that going to play into it?
I think you're right to be cautious and I think there's some advantages and opportunities that have to be really carefully managed. I mean, there's some really simple ways that it's already supporting things like minute and note taking, which is reducing administrative strain. So I think well governed and managed, there are some opportunities in it. But yeah, I think it's right to tread carefully in terms of how it can support healthcare.
Thank you.
Anyone?
Me.
Henry,
Yeah, councillor Henry.
Just a couple, and I really am hoping they're going to be quick, to be totally honest. Getting down to the RT, I'd noted the RT stuff. Now, I've worked and known enough mental health people to know that actually IT can be one of the most frustrating bits of it all. So you're trying to get help, but you can't get help because your IT is either not connecting properly, and that can actually escalate their mental health. So, and then you've got your older people with technology issues, and personally, I don't even use that app. I do, it's good. Some people use it and they really like it, and some people use it and they really, really
There's
don't.
got to be a transition, hasn't there?
Yeah.
That makes those options available. And I think the other thing, which is again going back to the partnership, where the partnership can gain strength and grow, is that not just having people around that table that are from health and care.
They just
but
need to
looking
save
at
money,
housing, looking at that information technology. So because there are so many other things that contribute to our health and care, not just the direct service provision, but it's about that wider conversation, the wider determinants that impact on us. So yeah, I think
It is,
that's good.
One of the other things was around GP access. Now I know that some people think things are getting better. But actually, they're only getting better because you're getting a phone call. You're not actually accessing your GP. And getting back to this sharing of, I will declare an interest here, Chair, because actually I've had some health issues with myself and my granddaughter recently. So, and I'm not going to get into that. But when you're asked and your local doctor is in your local area, you've been with the same doctor moving around the city, which I get because it's quite a good thing to have that in some place. Yeah. But then you're asked all of a sudden that your doctor can't see you at your surgery. Can you go to Watch Park? Right. And I'm sat there thinking, well, that's a 2 hour drive or a 2 hour trip for me on a bus and 2 hours back and everything else that goes with it. But then you talk to your receptionist and they say, well, that's the only thing we've got. Right. And the other issue was around patients waiting for medication. Now, this was something I saw in my local surgery. There was a woman come in. Her parent, she was a carer for somebody, and she was having serious issues trying to get that medication. And then it was, oh, you can't have it because you've got to see a doctor. Well, can I have an appointment for a doctor? No, we haven't got one for a fortnight. Right? By then, people are dead. It's like the primary care for me is the minute you see your doctor, and then your doctor refers you off. Now, some of the stuff missed in the doctors is because they're not seeing doctors. Right, and our doctors are going, well, I work that surgery Monday to Tuesday and I work that surgery there. So it's about, like you said, the continuous care.
I think there's a lot to do in terms of reducing variation and improving that quality, which I think needs to be fed through it, because I think we've got pockets of things that work really well, and then experience proves that that's not working well for everybody. So I take your point, and it's
Whether if it's health, schools, whatever, I've never ever found bigger, better. And it's something I've seen since I've sat here. I've never ever seen anything there that's bigger and better. Jean Bishop is a perfect example of local community care.
Councillor Henry, if we can just.
Sorry, I'm done.
No, I'm just thinking, we need to show this, in September, we've actually got the primary care directors coming, are they coming here?
Two clinical directors, Eric, bringing an item specifically about primary care.
Now, I just want to get across, because if they're sitting at the tables now, moving forward with plans, then things need to be in early.
Next meeting, we can address the people that do that directly, can we? Eric?
Yeah.
Which is good, really good, yeah,
Oh, yeah.
but thank you. So, I think that's.
Yeah, no, just going back to the AI and how it can be used. Sorry, Fiona, I'm gonna have to say declaration of interest on me, the patient group thing.
Oh, yeah.
With the St Jude's Voice group, we went to the Bishop Centre to have our meeting, and one of the clinicians came in and talked about AI and what he can use it for. Because we thought AI, oh gosh, but he said it's useful, so he can spend more time with the patient, because the AI is taking, instead of him writing notes, that deals with it and transcribes it for him. And he can add to it as well or whatever, but he said it will make such a difference. Because we were thinking, oh, somebody's going to sit there and talk to you that's confused fast. So that, that was really good, how he just explained it and showed us, etc. So I can't see a problem with it as long as the IT works, etc. Not like in this building.
I'm based in this building.
Don't work anywhere in the city.
Just wanted to mention actually was within the paperwork we've been given, etc. It talks about for the future, free shifts from hospital to school, blah blah.
Yeah.
No, I thought the one. I think. 2-3 shifts from hospital to community, from analogue to digital, and from treatment to prevention. I've had an email today. It's following to do with the petition to the government about testing type 1 diabetes, testing, and the government have responded to the petition to say NHS England provides diabetes care in children due to insufficient evidence supporting routine mandatory testing for paediatric type 1 diabetes. It has no plans to introduce this at the current time. Then it goes on to talk about what a type 1, the test you need to do. But it's up to the National Institute for Health and Care Excellence, NICE, to provide guidance, quality standards on the treatment, blah, blah. And the, yeah. And it says NG 18 guidelines, take one section that provides clinical guidelines for diagnosis, treatments and care for children and young people. It states that clinicians should be aware of the signs of type 1 diabetes in children and young people, including blah, blah, blah. The NG18 also recommends that children and young people with suspected type 1 diabetes are referred immediately on the same day to a multidisciplinary paediatric diabetes team with the competencies needed to confirm diagnosis and provide immediate care. And there's a lot of other, and there's it will be going to petitions committee. So I'm saying to members here as well on the political side of it, find it that you have MPs on it. We need to do that because I'm absolutely disgusted. Yeah, I was. The child that died in May, and for my granddaughter, whose 7th anniversary is next week, the competencies of the NHS staff was disgusting at that time and still is by that 2-year-old. And I know it's not your fault, Erica, and I'm not blaming anybody in this room, but actually to see that this morning, and I haven't read everything, but actually to see that, it's a kick in the teeth for that family and for lots of families. Yeah.
I think we all need to support their event on the 10th of August. don't
Yeah.
we?
Yeah. But I think,
I know
yeah,
that
so I
we
just
go
thought, because I decided to put it off so I can look at it properly. But I think it does need highlighting that actually that is prevention, a simple test. Yeah. But the NHS and the staff, and it was primary care as well as hospital staff, and with that 2-year-old that didn't deal with that. And I remember with my granddaughter, the consultant at the hospital, when it was diagnosed, and everything else that could have happened, she'd been to the hospital over a week before, even though she was really, really ill. And he said he could not understand why that doctor at that time that saw her, that just said, give her this because she's got constipated, didn't do the test. And it's still happening. So, yes, sorry, everybody, but I just felt it. So if people haven't got that email, which a lot I know will have, I was in tears. I was in tears by the time I finished reading.
Glad
you read it all. Yeah. Yes, we'll do.
Do you need to circulate it to all the members?
Yes, please.
Yes,
Okay.
please.
Yeah, you could send it to me, councillor.
I will do, yes,
Yeah,
that's
thank
fine.
you.
So thank you. Sorry, Erica, I knew you would as well.
Yeah.
But, yeah.
Go on.
I mean, very briefly, I mean, my granddaughter's best friend is type 1 diabetic. She was diagnosed at 3.5, and that was because her mother had keto sticks in the house and noticed what was happening to her. And she did a pee sample, and it was obvious she was going into ketoacidosis, and she took her up to the hospital. If she hadn't had that knowledge, I don't know what would have happened. I don't think there is an issue around the quality of care for type 1 diabetics, also within the hospital system still, the paediatric side. But is this something that we, as a scrutiny commission, bearing in mind that this is something we feel strongly about as a council, because it was a unanimous vote for council, and I know many of us went out straight away and signed that petition for that work to be done. Is this something that we, as a scrutiny commission, can refer up through to the ICB for it to be included within your preventative work? Because it might only prevent 2-3 children a year, but the impact on the community that has is unbelievable.
Especially for something that is so simple.
Something that is so simple and cheap to diagnose. Yeah, exactly. You know.
Just thinking you could also ask for an update from the specialist diabetes service, the paediatric one at the hospital. You could ask them for an update here and some assurance around. We are working with the hospital on paediatric hospital at home for children with long-term conditions.
Yeah.
And how that's integrated with our community, specialist community, children's nurses, primary care and paediatric services. And again, it's around that move to not having to go into hospital unless you have to, but but having those specialist services being able to support you at home. So that is something we could look at in terms of the care of the diabetic child, but also you could ask for some assurance from the current services.
Chair, could I request that we actually do put that request through for a report and somebody come speak to us? Yeah.
Minute there.
Chair, can I just come in? Sorry, because primary care as well.
Yeah.
Because we've heard it was, even my daughter had such problems just with the with primary care. You know, these strips you get. She used to get challenged over why she'd had one prescription of 100 one week and she wanted another pack the next week. Why do you need more? You've had one. Because I need to. I don't know how many I'm going to take. I mean, all registered on the monitor now. But also, one of the doctors at the hospital when she died, because she had to go for checks, this was about 18 months ago, I think. The other doctor rang me to say, can you ring her? She'd walked out of an appointment because the doctor, she just said she needed fresh air. It wasn't, she was absolutely in tears because the doctor turned around to her and said, if you don't get this thing right, you will kill your daughter. What is that? That's
I mean,
totally
Those
unacceptable. That's what that
I would
is.
encourage those kind of individual experiences to be fed back through the PAL centre. I know
Which
people
did tell them the next time, she just said, I do not want an appointment with that person again.
Yeah.
It's important.
That's
It's important.
the surgery.
These things are fed back to the
Yeah, I mean, we complained about the GPs as well, but I didn't get anywhere. Thank you. So sorry, I've just,
No,
yeah.
Yeah, you got downloaded on there, didn't you? Sorry, Erica.
Yeah.
Sorry, Eric.
People thought I was downloading.
Thank you.
Well, it's good that you to know anyway, because, you know, you may not get to know.
I'm just going to throw one more thing in
Yes.
before we go. You've got in here, there's a recommitment in Kingston analysis, recommitment to roll out single patient record. Now, I'm going to declare an interest that I've been an IT geek since I was 4. So about 12 years ago, I was working in a data center and I got a delivery, which was the largest data server in the UK at the time. It was for NHS patient records. That's 12 years ago. What's happened in the last 12 years? And is this a real commitment or is this just another political sort
I
of?
think it has to be a real commitment because I don't see how the other initiatives can really work and be effective without it. So I think it absolutely has. And you're right. I think the NHS and social care embarked on this, but some of the mistakes and lessons learned are too many systems and not bringing it back to one. So yeah, but absolutely, it's got to be a priority because it underpins everything else we want to do.
And then my other comment's going to be on the new GP contracts with either neighbourhood providers or multi-neighbourhood providers. Will patients have the choice to go with, because for myself, for example, I prefer having access to a very wide range of services and specialists. So I'm with Haxby because they've got a lot of staff, and it means I think I've spoken to my GP 3 times in 12 years. But I've got access to mental health care, I've got access to diabetes care, I've got access to all the specialists I need in various departments in that. Whereas others, I know, so I'm a transaction, I consider myself wanting transactional healthcare.
Yeah.
Whereas other people do want relational, where they do want to see the same person over, every time. Will patients be able to choose that?
I think patient choice has got to be paramount. And I think obviously the model has got to develop, and it's got to develop in co-production with people who ultimately use the services, which is all of us. I think that there's still an option to have your own GP and your choice around who that is, but still have access to that wider neighbourhood health offer. I don't think it'll be one or the other. That makes sense. I think the GP service is part of the neighbourhood offer. Makes sense.
Okay, thank you.
Thank you.
Okay.
Thanks very much.
Thanks, Erica.
Thank you, Erica. What was next?
Health and Care Partnership.
Yes, we are. Public Health Directorate Revenue Monitoring, Teresa.
So that's part of that report. I've got smoking sensations.
Yeah, yeah,
Yes, my skin.
Morning, anything that you would like to add to the report that we've got in front of us?
I did that it's very early report at period 2, and we would assume that everybody's read the paper and we're just taking a question.
Okay, so there's nothing else you'd like to highlight. Any questions? Councillor Randall.
How confident? Okay. I tipped you on the ankles of the closer. No, never mind. How confident are you that the overspend that you currently have is not going to increase? You know, let's put it as plain as it is. You know, we can see where you're overspent now and what your projection is for a year. And,
Yeah,
you know,
I think that as a
what do we need to do to
period
make sure it
2,
doesn't happen then?
going into period 2, then yeah, we've highlighted the overspend. However, there are risks associated with demand that we are flagging in the report. So in 4.6 and through other areas, and we are flagging that this position is at a steady state. Therefore, it is an assumption at period 2. Obviously, if demand increases, if inflation increases, then there is a risk that this will increase the overspend.
I wanted to add some more specifics about the risks. So the thing that we're having the most challenge with is that the level of care needs that people require are increasing in acuity. So people who are already in residential care, rather than us doing reviews and their needs staying the same, their needs are increasing, and that's meaning we need to put additional one-to-one into care homes, and that's increasing the level of cost per person. But then also we have had more people going into residential care recently as well, which again, the budget was built on a steady state because we usually say a steady state. So, those two things are where the highest level of pressure is. Now, we are doing a lot of things to try and alleviate that. So, for example, working with residential care homes around assistive technologies to reduce the level of restricted care with one-to-one provision through the use of technologies, so that you don't need to have one person sat with one person at all times. We can do better with assistive technologies. So there are things that we're doing to try and mitigate it, but it's very difficult when the demand is there because we must meet people's needs and make people safe. So yeah, it's very challenging, but we are doing everything we can.
Okay, Councillor.
Yeah, so changing tack totally here. What safeguarding issues could arise from that? You know, if you're saying, well, yeah, you think this person needs one-to-one care, but we don't actually need to provide it because we've got this, this and this. What safeguards are going to be in place to protect that vulnerable person and also to protect the other vulnerable people that are around them? Because it's not always that person that's the most vulnerable.
So that is done with each person in mind. So each person would have a full assessment. It would be part of their care plan, and we would only do it where it was safe to do that. We wouldn't do it where it.
Just seeking a reassurance there.
Councillor Henry.
Just a quick one, actually. I mean, I get the budget's constraints, but I know you're saying that there's more going in than you were expecting. Are you doing like a trajectory on that?
Yeah, so we work really closely with finance all the time. So we do monthly meetings and we monitor exactly who's going in. But we're also bringing forward a new market position statement for adult social care for the CQC regulated services and day services. That'll be coming. It'll be coming soon as well. Yeah. And within that, we analyse population health data. We analyse what demand we're currently seeing. We look at themes and trends nationally and locally that are happening, working really closely with public health around the JSNA data on that. And so you'll see, yes, we are looking at future projections, how we really look at prevention as well. So we're going to follow up with a prevention market position statement and plan later in the year as well. So yeah, that will be coming.
Thank you. I look forward to that.
Okay. Anyone else? No. Can I ask you then, on the efficiency savings reports we've got here, some of these say 24, 25 rolled into. When you say rolled into, is that what we're continuing to make additional savings, or we're still saving this amount, or we didn't achieve this last year, we're going to try and achieve this year?
Yeah, basically it's what wasn't achieved last year that's been rolled into 25, 26. I think it's important to note as well that the service are working on the savings side. At the moment, they're all being predicted to be delivered. However, they're working on an alternative plan that will be brought back, and they may not be delivered exactly as they're set out at the moment.
Okay, so correct me if I'm wrong here, but so in those 1, 2, 3, 4, 5 categories last year, the savings target and savings to be achieved are the same. Was that the same? Were they the same figures that were expected to be achieved last year?
So yeah, at the end of 24, 25, there was a savings plan of 645 that was expected to be delivered, but wasn't
We
delivered.
couldn't deliver that.
We couldn't deliver that in that form, yeah.
So how could the commission be assured that you're going to be able to achieve that this year? And that's not a criticism of your service. It's just, as we know,
Yeah.
this is probably one of the
That
most
is
difficult
why
things.
it's really important to understand that all those, the 2.1 million are being reviewed.
Right.
Because there is a difficulty in delivering it as it stands in that format. Therefore, an alternative plan will be brought back, but for the same value.
And the 773,000 predicted overspend is assuming we achieve those savings.
Yeah.
So, I mean, not wanting to be the harbinger of doom, we didn't do it last year, not for our own fault.
Yeah.
Just because the circumstances are what they are.
The 1.4 million overspend then.
Yeah, can we be real? Can we say that 773 overspend is realistic? Because I honestly, I don't see it.
No, it's a fair point, and that is how we're reporting it at the moment. But I think highlighting the risks and the level of demand that there is on the service, then it could turn out to be quite difficult.
So do you think that we should be presenting this as 773, or we should be presenting it as 1.2 million or 2.2 million?
1.4 million is left to together. So
Is it no?
645 and 773.
No, because we've got 1.5.
Another 1.5 over the page as well.
And then we've got 60. So that's 2.1.
2.1.
So that's, it's just that the difference between 750,000 and 2.5 million is statistically significant. So, I can't imagine what finance and legal are going to say at the end of the year when we say, actually, we predicted 750,000, but we actually went by 2.5. When
Just under 3 million, actually.
When we've actually lined out here that we are actually 2.5 million. This report to me reads that we're 2.5 million down, which isn't a problem. Well, it's a concern, it's not a problem. But what I don't want to be doing is telling finance that, and telling the ISMC that actually we're doing really well. We're at only 750 million overspend, when the reality of it is
just under 3.
I don't expect that we'll hit that.
Yeah.
So can I come back on
Sure.
that point? So in terms of the alternative saving plan, there's a lot of things in train that will achieve savings. So, for example, we recommissioned housing related support services last year and increased the amount of the amount of provision available, and that is offering a move on option for people that are in supported living, and we are achieving savings through that. Additionally, we're doing an assistive technology pilot, which I touched on around residential care, but we're looking at it across the care market, including community wellbeing providers. That has the potential to make significant cost savings. What we need to do there is pull out everything in the continuous improvement programme and those things I've just described to present the alternative plan. So we have some confidence that we will achieve savings. The problem is that if demand continues to increase and the acuity continues to increase, that we can make the savings, but then, and we're reviewing care packages down here, but then they're going up for new people coming through and for other people that are being reviewed. So it's really based on the information we have currently, that over £750,000 ovaries, that's what we believe is the current.
Okay, could I ask that for the next meeting, we have a progress report on the savings? Because, you know, at the moment, it's just telling us what we want to achieve. But, you know, obviously, the next report, then we've only got, what, 6 months left to the end of the year. If there's things that you need other departments to put in place, or you need assistance with, or you need people to help with getting pushed forwards, it doesn't give us a long time to achieve more of those savings in the year, or to just declare we're going to make them. But what I really don't want to be doing is saying we're going to make, you know, we're only going to overspend by £1 million if we're going to overspend by 3. So what I'm looking for really is just a sort of guideline at the next meeting of where we think we're going with that. Because obviously we're not prepared for that this meeting. So if that's okay, can you put that on the.
I suggest, Chair, that we cover that in the next revenue monitoring update rather than having another specific item.
Yeah.
We'll have it included in.
When's it due?
Quarterly.
Yeah, I think that, sorry, just to come back on that, I'm not exactly sure on the timeline, but there will be an alternative saving plan that's presented as part of the revenue budget monitoring. Therefore, it will come through the formal process. We'll see that and be able to comment.
Otherwise, it's getting easier near to.
Yeah.
So, yeah, we need something, even if it's.
Did you say for October then?
Yeah, even if it's not the alternative savings plan, we need an update on what is actually happening to produce that and where we are.
Yeah.
Because we'll start going into budget discussions in November.
Yes.
So yeah, so if we can have a really good detailed level of where we think we are in October, which is the next scheduled budget report, isn't it?
So, yeah.
If I'm asking too much.
No, I think it's a fair point. I think at period 5 we have a better. Obviously, period 2 is very early in the financial year. Come period 5, a lot more work will have gone into the monitoring and the information. Therefore, it will be a more detailed report anyway.
Good. Yeah, thank you. Any more questions? No, Councillor Henry, be quick.
I am trying to be quick. I very much want to reiterate your position. I've said this on another board as well. Sometimes I think staff can be under pressure to actually put something down to say it's savable. Yeah, and I really get that. So for me, I'd rather know if it's not savable quicker than not at all. So it's about it being really realistic as well, because we know services are going up. We know that's going to bring more cost. So savings are just going to disappear into different parts. So for us to help, we need to know when you actually can't make savings faster. So we can help and try and get resources from other places. So sometimes I think it's a chicken and egg, isn't it? You'll need the data later on. We need the data a bit earlier. And it's like, how do we work a budget that's not workable? Let's be real, children's services and adult services are really unworkable. So it's not, it's about being bluntly honest about your service, really. And then that way we can try and help you get more supplies and stuff. So it is, I'd rather have said no services can be actually, than because that's more realistic. Don't mean I don't want to see services like anybody else. Money's money. But yeah, it's a really interesting one, this one. Thank you.
Thank you.
Anyone else? Thank you very much for the
Get a
report.
true picture.
And, very much thank you for what you're doing. Because
Yeah,
exactly. We do all understand just how horrible and hard this is, and actually, you know, we care about your well-being as much as
Thank you.
everything else. And I think Councillor Henry put it better than I could in that, you know, this isn't about meeting the budget. It's about being realistic and trying to ensure that in future years we're not always setting unrealistic targets for the guys to try and get.
Thank you.
All right, thank you.
Now we're on the wrong spot with us on. Oh, I'm not saying a word because that's the next one.
Smoking services, which is really hard to say when you're drunk.
So what we've got in
We
there,
didn't hear that bit, Chair. So, yeah,
Slightly Irish.
It's like Irish.
just
Right.
introduction, Matt Fawcett is going to lead in terms of the conversation, so just let Matt introduce himself.
Yeah, morning everybody, I'm Matthew Fawcett, I'm the Health Places Programme Lead and I oversee Commissioner Manager and Smoking Cessation Sector. Yeah, so I guess just to highlight a couple of parts from the report really, we're obviously seeking endorsement into the re-procurement of the current provision. For clarity, the new proposal is that the contract will be split into two pots of funding. That's to tie together a smoke-free generation grant that came out last year that we're now in year 2 of. That way, if that grant does become unavailable in the future, we can decommission parts of the contract as and when we would need to. So that would be our preferred option. The aims of the service is to target smoking prevalence. There is a challenge that has come with the smoke-free generation funding, which is, as you'll see later on in the report, a target number of quits to achieve. That goes up rapidly every year now to year 5, which is daunting but a welcome challenge because we know that there are opportunities in the city to go after that. There's obviously some data sets as well in the report that just demonstrate where Hull are in comparison to the rest of the region. We do have our own challenges in Hull. Compared that to how we do regional, we stack up really well considering those challenges. So from a performance perspective, that gives us a lot of confidence in the service, which is why we're really sort of pushing towards the re-procurement of the current provision. And really just moving forward, there is also a data set about the targeted intervention we've done at ward level. We do have some real challenges in certain wards in the city. We do make sure that we work in a targeted way as part of a wider system. We are as well, as part of what's happening with the smoke-free generation funding, as the number of quits continue to grow, we're having to be really sort of flexible and adaptive to our referral process. So we've done a couple of things this year where we've tried to make the service user journey into getting a referral as streamlined as possible. It can take up to 7 interventions for somebody to quit smoking to come through our services. But in fact, the front door to that could be locked if they've got to do sometimes more than 4 clicks on a website. So with the service, and again, going into the performance of the service, have been really flexible over the last year, which has seen almost a 20% increase in quits from year 1 of the smoke-free funding, because they basically said, let's work with communities to be as flexible as we can. So we've done a host of texting initiatives this last year, which has led to prompted referral and supported referrals, which has led to more people coming into service. So to summarise, really optimistic with how the service has performed against some really challenging times and an increase of funding, which is tied, sometimes the increase of funding terrific, it's tied to a really challenging KPI. So we have to make sure we're meeting that. And also just thinking ahead of the opportunities with the upcoming legislation and sort of national context, that there's some real challenges, but we're optimistic the service can meet all of them.
When you say it's up to 7 interventions, is that up to 7 re-referrals to your?
Yeah, that can be 7 times that somebody has access to the service, whether it's through self-referral, and could be from a community referral. Just, I guess, for context in the report, self-referral is our biggest mode of referral into the service, followed that by our hospital. But we are getting a lot of self-referral, which is why we've tried to make that front door as easy to get through as possible.
And the numbers here for your expectations on quit attempts, is that on that number of people or the number of referrals?
That's number of quits that we'll achieve.
Right.
So by year 5, 3,500 quits per year is the aspiration. As you can see from where we are now,
a big aspiration.
It's a big aspiration, but it's one that the service have been really open to wanting to meet.
No, that's good. Any questions, anyone else?
Sorry. It says up here that people won't set dates, and I'm on page 30. That makes me think about vapes.
Sorry.
They won't set dates.
Yep.
So that makes me think about vapes. So if they're using the vape and they're ongoing issues that are coming to light with vapes. So if they're not setting dates and they're using a vape, what could be the consequences there?
Well, the vape part of this is really sort of complex because our service is commissioned to deal with tobacco addiction
Yeah.
and stop smoking. We're seeing obviously the recent introduction to the ban on disposable vapes. There's not my area aware, but the illicit market as well.
Yeah.
We're seeing some impacts there. We're also probably going to see a return to people return to smoking if and when they're not able to use vape. So there is obviously a mass amount of challenge that comes with that, and there will be people that vape that are just
And the
not.
reason I ask is most vapes have more nicotine than cigarettes ever have.
And this is the challenge we have with the market that's changing every day.
Yeah, and here's another one. I found out last night that there's a new product. Right, I've not heard of it before. I don't know how long it's been out. You literally get it and you just stick it in here and it's got nicotine in it. And actually it's burning people's faces, some of it, because they're flavoured as well.
Yeah, and they've been promoted, snus, it's been promoted by, it's even been promoted by footballers.
Yeah, I've
Stuff like that.
never really heard of it,
One
and that's
thing-
coming from a smoke.
Outside of this, I hope to give some reassurance. We have set up a vaping task group
Yeah.
to look at some of the challenges we've got vaping. That's led by the Healthy Places team, but it's working with children's services because as you can imagine.
Exactly.
the
And it's
increase
having an
there.
impact on the fireboard as well, because
Yes.
it's just thrown everywhere.
So we've done a piece of work, just on a screen, done a piece of work working with colleagues to try and identify what those key priorities for that vaping group are going to be when we meet in September.
Yeah, thank you. I was just wondering, because I can see on the figures, Orchard Park, which is the ward I represent, is the second highest after St Andrews and Docklands. So as councillors, what can we do? What can we do on Orchard Park? What's to work in partnership with yourselves?
Yeah, I think the simplest thing we could probably do is really highlight the referral process.
Yeah.
To you, because self-referral has to be the biggest referral, just highlighting there is a service and promotion of a service is sometimes enough to get people introduced. There's also around opportunities for our advisors to come to community. So the way that's happening there is because we've got advisors in the community, whether it's primary care or community events.
Yeah.
So it's also raising the awareness that if there's an event coming up and you'd like some representation from our service, then we can be there. So increased visibility, but also an increased awareness of referral pathways.
Yeah, that's exactly what I was thinking. Thank you.
I think
We'll be in
it's
touch.
Sorry, if I could just add as well, the conversation, it's out of the room now, but what we've just talked about in terms of neighbourhood model, you know,
Yeah.
coupling that as many front doors as we can get in terms of
School
making
coffee
sure
mornings.
we hit the really challenging. So I think members have got a really key role to play
Yeah.
in supporting us getting to those numbers that have been set nationally. So
Yeah.
we've really welcomed ideas and opportunities, as that said,
Yeah.
to do that best we can. It's a shared endeavour, this one.
It is, absolutely. Thank you.
If I could highlight an example of that working, so I mentioned the text initiative work. We started a year ago with a piece of work where we text every social housing number and
Good.
offered a introduction into the service. So here's the link, go find the referral. Really young, low yield in terms of people following that process. So we reflected on it and then we went to primary care and the text message said, would you like to be referred, yes or no? And somebody from primary care triggered that referral on their behalf. As you can imagine, the numbers went higher. We then did it again with COPD focused patients, the number went up again. So we're being slicker about how our community interventions look and trying to work with more PCNs as well as we move this forward.
Yeah, yeah, that's great. Thank you.
Right.
Thanks, Jay.
Anyone else?
I'm all right, I've got the lowest ward.
I
I have the
would
lowest
like to
numbers
see
on my
tobacco
ward.
sitting, because that's another thing that's coming through, isn't it?
Sorry,
Heated tobacco products, do they come under smoking or do they sit in yet another category of?
if I'll say this, it's nothing we're hearing within our services.
Right.
So it's not, we're not hearing that from people that are coming through our services. We're not hearing it in our sort of partnership discussions. Our service are getting predominantly through heavy smokers at the moment. So we're not hearing it. It's something though, however, similar to the comment made about the nicotine in the gum, we will continue to be open and sort of see what the opportunities are to help communities as and when these present to us.
And of these referrals, do you have like an age limit? Is it these all adults or do you do?
Our service works from people 12 and above.
12 and up?
Yep.
Okay. Are you seeing increases or decreases in referrals from that age? Are schools referring, things like that?
Well, we're seeing an increase in referrals right across the board because of the new interventions and new funding that we've been given. So we're trying to target everybody, I suppose. We're not necessarily, we're seeing probably our proportion of percentage has been the highest recently has been manual workers, so that's probably age-wise 13 and above. That's because we've done some targeted work in those areas as well. The reality is wherever we target our interventions, where our referrals will probably spike over the next quarter. Within our self-referrals, though, it is probably that 30 to 50 age bracket where we've seen the biggest spike. But I also think that that's probably, again, in alignment to some of the initiatives that have been rolled out through national legislation.
Okay. Councillor Randall?
Yeah, thanks very much for what you've just said. And I'm sure it's something that we will all take on board about getting it down into our local areas a bit more than we are at the moment. Chair, within this report, we've been asked to approve some recommendations on paragraph 3 of page 34. Could I move that we agree with those recommendations?
You want to second that?
Yeah.
Yeah, fantastic.
I'd go with option 1.
Show of hands on accepting recommendations.
Just provide additional assurance. So this is the second journey, if you like, that the public health came through the provider selection regime that there has been quite a lot of noise in the system more recently about that. So we're extremely confident in terms of advice and support we've had through legal and procurement, coupled with the service evidence that occupancy is absolutely right.
Do nothing.
No, sorry.
Yeah, you
um,
need option
provide
1,
PSR.
6.1.
Yeah.
Yeah, that's.
Well, that's what I said wrong.
So it's option C, so continuation of existing.
That's okay. Yeah.
So yeah,
That's why I said it, yeah.
option 1. Go for it.
Got 3 options, haven't you?
Where are we
Yeah.
next? Problem from Paul. Just before we pick that, I need to officially propose that we move that into. Before we start this one, the next item is now I'm proposing to make the next one an informal discussion so that we can exclude the public. So not this item, but the next item, which is regarding task we finished panel on mental health. We've got any objections to that?
No, I think we need to have an honest discussion.
Okay, great, fantastic, thank you.
Staff motion, not really both motion.
So I'm not Sally, I'm not Helen Christmas, I'm Sally Barlow, working for the health team with Helen. Helen's not here today, so presenting the paper and also.
My name's Will Adam, excuse me, I work in health as part of the trauma informed project team as well, and I'm Sally.
Anything you want to say before we start questions?
Yeah, I guess just to highlight, if I can share, the self-assessment toolkit, which is referenced on paragraph 1 on sort of page 2 of the report, and it's also included as your appendix. The toolkit is NHS funded work for children and people, but in reality, it's suitable for all age. And a number of organisations, our Wicklow Council, such as Humber, are currently using the toolkit to roll out. In terms of our sort of direction of travel, from a public health perspective, we're looking to sort of try the toolkit out over the autumn period, with a view to going to CST for a sort of a wider whole council commitment early next year at the latest. And we're also sort of at the same time sort of collaborating and sort of influencing sort of partners, I guess, around the sort of wider city rollout of the toolkit. Just to say, just really very briefly, just a couple of points around the sort of the value of the toolkit. I think sort of fundamentally it kind of promotes discussion. You know, in terms of sort of how we respond to trauma, how we adjust trauma, which you know absolutely impacts everybody sort of differently. And obviously you go through the process, you sort of evaluate your sort of your current practices against those kind of sort of principles. You know, where are things working well, where are your sort of strengths, where are the areas for improvement, where are the areas for growth in sort of trauma-informed practice. But I guess ultimately it's all about improving outcomes for those who are experiencing trauma. So I'll probably
stop at that point, Chair, but if that's okay, and just obviously welcome questions.
Questions from anyone?
I'm quite happy to see it going forward. I will wait until we see some results.
Yeah.
We all know what I think of this. It's been needed about 50 years. It's not longer in this city.
Happy to see
That I
the
think
start
it's
of
a
the
really
process.
positive move. I'm obviously familiar with the tool already, so I can see how well that embedded into the services. So
Yeah.
I think it's reassuring to hear that you're also expanding and looking at trying to attract other services as well, not just DC, but
Favour, but we're taking it on.
When you, councillor. Again, Randall, I'm saying, I'm not doing names, I'm so sorry. Sorry to all of you as well.
All right. I'm just wondering, how is this linking in with CAMS? And are we offering this out as a self-assessment via CAMS to younger people? Because we do know that there is a heck of a waiting list for CAMS. We offer autism assessments online for those that are happy to do it, but those who want to do face-to-face have to wait even longer. Is this the sort of thing that we could work with them as a partner on? Because a lot of the work that young people have around their mental health issues are trauma related. You know, let's be perfectly blunt about this. Even if it's because they're autistic and they're not being responded to correctly, that's a trauma to that child. If it's a child that's in a relation, who's in a familiar relationship, that's a toxic one, you know, that's trauma to that child. So how are we working with CAMS, both on North Bank and South Bank, because we're aware that it covers both, but to ensure that they are accessing this, helping support the young people that they're working with in a more productive way than just saying it's CBT that you need.
Yeah, I mean, I think what's important to point out is that there is a bit of a groundswell in terms of, you know, not just on City Council, but other partners in this, and they're embracing the trauma-informed approach. And I know that Humber are quite far along. They're part of our steering group that we hold. And in terms of sort of self-assessment model, they've developed their own, which is similar to the one that you've got in front of you. So services, you know, Humber services are the, you know, the way that those are being rolled out are becoming more trauma sensitive across the board. So obviously that does feature into, you know, the way CAMS are operating as well. And I know that some of the training that we've delivered over this last year, there has been CAMS members of staff that have come under the trauma-informed awareness training and things like that. So I can't answer specifically about CAMS in terms of the service, but I know that generally, you know, in terms of Humber's approach to trauma, it's quite, you know, they are well down the route of becoming, you know, trauma-informed, trauma-aware, trauma-responsive. And linked into sort of a steering group, which is sort of a strategic group, I guess, that looks at kind of overall across the city, how are we becoming a more trauma-informed city.
And are we working with other health partners other than CAMS? You know, obviously as a council we're doing this. Are we working with the hospital trust on this? Are we working with the HCP on this? Because obviously, you know, they will come across people who are suffering from trauma, who don't know they're suffering from trauma, and might be able to use this as a steer for getting help.
Yeah.
For those individuals. So are they a part of the steering group as well?
Yeah. They're sort of part of the wider network.
Yeah.
Also organisations like Hungry Short Your Mind.
The emergency services?
Are you
Because
obviously doing it? That's what I was about to say.
Because obviously, you know, they all have occupational therapy departments. We were just hearing at the beginning of the session from the ambulance service about their members of staff who are subject to physical, emotional, mental abuse. You know, that obviously that can be very traumatic. If you've gone to a particularly nasty incident, that is traumatic. Are they picking up on this sort of stuff as well?
I'm just trying to toolkit, you know, it's branded Health and Care Partnership. So in terms of all the partners that partnership operate with, there is an opportunity, some through directly commissioned services, they can embed that. I suppose the particular focus we were here to say, you know, Hull City Council has got a job to do here in terms of becoming an exemplar. And as the public health team, we're going to pilot it and try and drive that through our organisation. Part of that is to say, if we're on the front foot as an organisation, those areas in the system that maybe aren't quite picking it up, yes, or I've got that, we're in a much stronger position, I think, to drive that, to say, here's our experience and how we've done it. So I'm sure there's pockets of the system that haven't touched this yet, but as we've already heard, there's also commission services out there in the health system that are using this now. But as I said, I think groundswell's a really good term. It is becoming a movement in its own right. So I think it's just being at the top of the wave of that and making sure we're driving it through.
So you're building up a head of steam then?
Yeah.
So, Councillor Thompson, did you indicate something to ask?
I was going to come back. See.
Yeah, I'm sure you actually indicated first.
All right, yeah. I don't indicate 2 minutes ago. It's off with steam.
To say really, the reason that I really like it as well is the fact how holistic it is.
Yeah.
It's looking at not just the families and the residents that we're working with, but it's looking at that whole institutional of work and how we support our staff members with their own circumstances or experiences through work, and how that transitions through how we deliver and communicate with clients, with patients, with our residents as well. So I just feel it's worth mentioning. It's that holistic approach and how it just emphasises and
Just found that.
Councillor
Yeah, I do have a question. It's not a question, it's a statement actually to do with some stuff. So when I got, declaring interest, because I'm going to talk about it, sit on the fire board. So I sit on the fire board for the whole region, and we was discussing this week, actually in our HR. So how they're actually planning on taking this on board as well. So how that helps with their staff because of the triggers and all the other stuff. And when I speak to people like Renew or Pause and stuff like that, this is already hitting the streets. It's already in the system. They are actually starting to use this sort of model already. So I think adding all this just helps even more.
So I think, sorry, I'm going to read that.
Sorry, I'm just, you know, I'm like, I've always like wanted this. It's something I've always
Because
supported.
there's such a groundswell, because people are sort of starting to use this terminology and understand what it means. I think a really important thing from a system perspective is this sort of pledge model. A lot of the sort of areas that are more a bit further down the line in terms of trauma reform have a pledge or a charter where different organisations across the city will sign up to that pledge. And as part of that pledge, we can say that you need to do a self-assessment and action plan. So then we can all start to understand who signed up for the pledge, whereabouts they are on the journey, and we can start to sort of cross-reference that a little bit, learn from each other. And that's almost going to formalise this process, because there's pockets of work that are taking place that are absolutely fantastic, but we don't necessarily know about it, or it's linked to other parts of the system. So, you know, recently the strategic group or the steering group have endorsed the pledge model. So that's the kind of next thing that we're going to start to look at, is how we can develop a pledge for the city, you know, which we encourage organisations to sign up for. And then we can understand where we all are as individuals, but then have a look collectively of what.
Have you worked with Room 42 on this?
Not directly, actually.
See, Room 42, sorry, Chair. Room 42 is ex-care children, and they help and support information. So I was at one of their briefings. They do their own meetings and all sorts. Yeah. So I would suggest you talk to them and actually get through their door as well, because these are the kids that suffer the most trauma and go into the adult services. So for me, that is a big thing. It's a big link to the care and the systems within our own systems. But they have a really big voice, and they're very good at telling you what they want to say. And they're highly intelligent as well. I mean, I would But sadly, these are also the children that end up in our prisons, mental health units and everything. So
They're the ones that have grown up in toxic environments.
they are, but they are actually the ones that actually have had probably one of the biggest understandings of trauma and how it can impact through life, not just in that moment. So yeah, thank you, Chair.
Anyone else? No, we don't have the recommendations, do we? Do we? Yeah, we do.
And I recommend you send them the contact details for room 42. You've got
Contact with them as I will, yeah.
So I was asking just to make sure. Sorry, Chair.
Okay. Well, thank you very much for what you're doing. It is very, very well. Thank you.
Thank you. Chair, before we go on to the recorded version
Yes.
and make somebody do their own work. I don't know whether members around the table and staff, etc. It's Fiona's last health scrutiny.
She's retiring.
Yes, she's retiring at the end of August. She's keeping very quiet.
I am.
I just thought,
You could just so young.
Oh, thank you, Chair. Yeah, I reckon got another 17 years since we took my state pension.
Well, it was 20 you told me.
Sorry.
No, I just to put it on record, which I know she's not writing it down, but
No,
it'll be written on this one. Well, Sydney, I'll put it on record. Our thanks for all the work she's done on health scrutiny.
Yes.
A lot of the extra work she's done. Keeping officers in check across the council.
Keep it us in check.
Keeping us in check. And our external ones as well. But no, thank you very much, Fiona. And I just think it needed to be said before you do.
Thank you.
Thank you.
Very sweet.
It's all right, you're only supposed to bring it all together.
I've
Yeah.
had extra copies.
Yeah.
Man.
Exactly. It was right, wasn't it, with that one?
We need to get it.
You'll be pleased to know that Anthony is temporarily taking over health scrutiny. Obviously, he's the health guru anyway. It was his country previously. The application is closed on Monday, so they're looking to take on somebody else, but they'll need training. And getting to grips with scrutiny, never mind health scrutiny, which is different.
Never mind.
I've heard health scrutiny in the right time.
Are you going to be tuning in and watching?
So,
When you're sat on the
beach with your feet up somewhere.
You'll be able to help yourself.
The corridors aren't they, like the ghost of scrutiny.
You could come and sit on the chairs at the back and glare at everybody.
Quite like you will do, but thank you all. You've been a pleasure to work with, including officers. And yeah, I shall see you around because I'll retire and I'm like, what am I doing with my life now? I know I'll go into rebuild on. So thank you all. Thank you.
Thank you very much. Really. Right.
Are we going to see a councillor Fiona soon?
No. Councillor Dad has already got me lined up for Lib Dem work. I'm like, no. No, thank you all. It's been a pleasure.
Never at all.
No, I shall miss you all.